Hello. I'd like to thank Dr. Nazi as well as Dr. Sandra Winkler and Second Life for the opportunity to speak with you on this innovative platform. In this day and age, the education of patients on their conditions as well as their different assessment and management strategies has become more feasible on a wider scale basis with the help of technology. The change in how we can disseminate and share information will hopefully promote a shift in the paradigm of healthcare from one in which the clinician takes a very authoritative position and conversations about care are very one-sided, to one in which the physicians, therapists, nurses, and remainder of the treatment team are facilitators in an open conversation about care, and the patient assumes both the right and the responsibility to take an active part in his or her recovery. I think the need for this kind of open, informed conversation is probably the most apparent in the treatment of pain, which is what we'll be discussing today. So what is pain? Shown on the slide are two definitions. The top is from Merriam-Webster's dictionary. It defines pain as localized physical suffering associated with a bodily disorder, as in a disease or an injury, a basic bodily sensation induced by a noxious stimulus received by naked nerve endings characterized by physical discomfort. The bottom definition is from Stedman's Medical Dictionary, which describes it as a variably unpleasant sensation associated with actual or potential tissue damage and mediated by specific nerve fibers to the brain where its conscious appreciation may be modified by various factors. While there are obvious similarities among the two definitions, such as a description of pain as suffering and unpleasant, there are a couple of instances in which the medical definition is perhaps more helpful in our understanding of pain. First, it points out that the sensation is associated with actual or potential tissue damage, meaning that there are certain instances in which physical damage may not have actually occurred to cause the pain. This will become important when we talk about some of the different types of pain that may be associated with amputation, particularly phantom pain, where most often there is no new or ongoing damage. Secondly, whereas Webster's dictionary states that pain is only received by nerve fibers, Stedman's makes a distinction that this is something not only received, but mediated by nerve fibers, and therefore can be modified by their interaction, either for better or for worse. So what then can we determine from these definitions of pain? Well, we can acknowledge that pain is a symptom and not a diagnosis in and of itself. This is an important distinction to make because very often among patients and clinicians alike, treatment of the pain itself can be the overwhelming focus, while treatment of the cause goes to the wayside. If I were to ask you what would be a more effective solution, placing a bucket under a leaking roof or patching up the hole causing the leak, all of you would say fixing the leak. Same goes for pain. Secondly, we learn that pain is subjective, and therefore, one person's experience of the same noxious stimulus may be very different from someone else's. Pain is also something modifiable, and we know this because there are instances in which the same painful stimulus is experienced differently. For instance, when someone takes a hard hit while playing a sport, which doesn't bother him or her so much in the moment, it can become much more uncomfortable hours later after the game is done. And finally, pain is variable, meaning that it presents in different ways. Not all pain is the same, and so the approach to treating pain should not be the same every time. To demonstrate how pain is transmitted, shown on the right of the slide is an illustration of the pain pathway. From this, you can see that a stimulus is received from the pain-mediated fibers, shown in red, in this case from the foot. They travel up the spinal cord and cross over to the opposite side before traveling up to pass through areas of the brain before finally being received at the surface of the brain in a location called the somatosensory cortex. What is important to note is that anywhere along this pathway, the pain signal can be modified. Pain may be amplified, as it can be with chronic pain or hypersensitivity, or it can be dulled. Signals traveling both up and down the nervous system are what modulate that sensation. When we approach pain management, we do it methodically, as you would approach any other problem. The most effective way to deal with pain is to identify the cause and, of course, address it. As this may not be such a clear-cut thing to do or may take some time to achieve, we also address the symptoms. As there may be multiple causes for the pain that is being experienced, or because there might be numerous factors influencing that pain, we try to use multiple approaches to create the most effective management. Finally, our ultimate goal is to modify that pain response for the better. At this point, I've alluded to the fact that there are numerous possible causes for pain or pain generators related to amputation. Some are more directly related to the amputation itself, more specific to individuals with amputation, while others are secondary or associated conditions. What you see on this slide is not a comprehensive list, but some of the more commonly seen issues, each of which I will be discussing through the remainder of this talk. Some issues, such as ischemic or circulation-related pain, are much more common in lower limb amputation due to complications of vascular disease, whereas other types of pain are more widely experienced. When I speak of post-operative pain, I generally mean that to be pain that is experienced in the days to weeks after an amputation that are directly related to the procedure itself. Having an amputation, as with any other major surgery, is very physically traumatic to the bone as well as soft tissues. In the absence of any new injury to the limb, this pain is something that takes time to improve, and it is expected to gradually get better. Until it subsides, the treatment is largely symptomatic. My main goal as a rehab physician is to improve someone's function, and therefore my primary goal in managing this pain is to reduce it sufficiently so that it does not hinder participation in therapies that a patient needs to improve, either because the pain is so disruptive that the patient cannot continue a task, or so bothersome that it isn't allowing for a reasonably restful sleep so that the patient has the energy to participate in therapies. For this, we use a number of different medications, some as mild as anti-inflammatories like Tylenol, and some as strong as narcotics, depending on the severity of the pain. In many, if not most instances, it is not reasonable to strive towards complete absence of pain because the amount of medication, particularly narcotic medication, needed to do so will subject the patient to counterproductive and potentially serious or even life-threatening side effects. For example, constipation, tiredness, confusion, slowing of breathing rate, and even death. As the swelling from the surgery can contribute significantly to this discomfort, residual limb shaping and swelling management, for example with ACE bandage wrapping, as shown in this slide, can produce a measure of comfort. This is something that the patients can do on their own, but instruction by a trained clinician is important, since improper technique can put the individual at risk for skin breakdown, and overly aggressive wrapping can worsen pain. Phantom pain is clearly a discomfort that is very specific to individuals with amputation. While there are other phantom sensations that a person may experience, such as simply the sensation that a limb is still there or that it is moving, phantom pain is a sensation that not only is the amputated limb present, but that it hurts. The reported incidence of this problem is quite variable, but with a good portion to the majority of individuals with amputation experiencing phantom pain at some point in their lives, this is clearly a significant issue. To the right of the screen is an artist's depiction of different ways a phantom limb sensation might present, with the hashed areas representing the perceived phantom areas. As shown, this may include all or only part of the missing limb. Another phenomenon that can occur is one of telescoping, as depicted in the middle illustration on the leftmost side of this picture. With telescoping, the very end of the limb is sensed to be sprouting from the end of the stump. In this case, the phantom fingers coming from the upper arm where the limb ends. While phantom limb sensations can be represented by such pictures, as depicted by an artist or even drawn by individuals with amputations themselves, pain itself is more difficult to depict visually, since pain is not visible. Drawing what pain feels like, therefore, is very abstract, something like depicting music or sound with colors. However, some qualities which have been attributed to phantom pain have been squeezing, stabbing, throbbing, and burning. As far as the pain pathway goes, and I've repeated the pain pathway illustration for your reference on the right. Once again, a noxious stimulus is received by the peripheral nerve and transmitted all the way up the nerve, then the spinal cord to various parts of the brain in order to create what we perceive as pain. When a nerve is cut or transected, as happens with an amputation, changes can happen all along the pathway from the peripheral nervous system to the central nervous system, meaning the brain and spinal cord. These changes are attributed to a concept called neuronal plasticity, where the nervous system is not a fixed system, but can go through changes in signals. For example, the spinal cord can undergo sensitization, in which the signals that normally inhibit pain signals are proportionally less than the signals that transmit pain. Ultimately, the signal reaches and is modulated by the brain. So the phrase, "it's all in your head," applies in the literal sense, but not in the sense that phantom pain is imaginary or fake. In the brain, sensation from different parts of the body are mapped out along the brain surface in the somatosensory cortex in a predictable fashion. This map of the human body on the brain is termed the homunculus. You'll notice that a larger area of the brain is dedicated to some areas of the body, such as the face and the hands, which is understandable because sensation from these areas are a very big part of how we interact with our world. Also notice that as a geographical map of your body, certain areas are closer to each other, again, as the face and hands are, or others further away. When there is no longer a normal signal coming from a limb, as in the case with amputation, the area of the cortex that used to represent that part of the body does not physically die off, but adjacent areas of the map invade the area representing the now missing limb. This is referred to as cortical reorganization and has been shown on functional MRI studies where a person is touched on the face or asked to perform a movement with the lips, and the area that previously represented the hand lights up. Conversely, a patient is asked to think about moving a hand which is now amputated, and the adjacent area of the brain representing the face shows activity. This is demonstrated on the image shown to the right. In the patient without phantom pain, the signal is quite similar to an individual with intact limbs, as you see on the two images on the right-hand side. However, you'll notice in the leftmost image, the individual with phantom pain has an additional adjacent area of activity with improvement in or resolution of pain. These signals are shown to normalize as well. So now that we understand better how phantom pain works from a neurological standpoint, how can we guide our treatment strategy? From a medication standpoint, what we are aiming to achieve is modulating that sensitization that occurs within the central nervous system by overexcitement of the nerves. As it happens, many of these medications are medications that are also commonly used in treating nerve-related pain or neuropathy, as can be experienced from diseases such as diabetes. Therefore, as we are dealing with overexcitability, it makes sense that the medications we choose include those that mimic neurotransmitters that inhibit rather than excite nerves. One such medication is gabapentin or Neurontin. Other first-line medication choices include a number of antidepressants. The mechanism by which these work is not as clearly understood, but it should be pointed out that even though this may be a medication option, this is not to imply that phantom pain is due to depression or isn't, quote, real. In fact, oftentimes, the doses of antidepressants used for pain relief are significantly lower than those shown to have a therapeutic effect on mood. Finally, as far as oral medications, as much as we physicians may be reluctant to admit it, narcotic medications such as morphine or oxycodone do improve phantom pain, and do so by working directly at pain receptors. However, due to the obvious potential for dependence, addiction, and other side effects, these medications are avoided if another alternative can be found to provide adequate relief. Other less commonly used treatments for phantom pain include medications, to the skin either in patch or cream form. These medications can include anything from anti-inflammatories to numbing medication to even some of the medications previously mentioned like gabapentin. The proposed benefit is that these medications are delivered directly to the area of discomfort and do not have to circulate through the entire body as a medication taken by mouth does. However, they are less commonly used because their effectiveness is somewhat debatable, and generally these medications need to be specially made to order by compounding pharmacies and are not usually covered by insurance. Another treatment that does not involve medication is transcutaneous electrical nerve stimulation, or TENS, which is shown in the picture on the right. As you can gather from the name, this uses electrodes to pass an electrical signal to the nerves and is utilized on the concept that a non-noxious or less noxious stimulus, such as low-level electrical stimulation, can inhibit nerve input from a painful stimulus. As far as procedures or surgeries to address phantom pain, for completeness, I've included a list of treatments that have been suggested or attempted. These include botulinum toxin, for example Botox, either to the skin or underlying muscle, nerve blocks, and surgically implanted devices called spinal cord stimulators. However, their benefit has either only been suggested by case reports or studies performed on either a single individual or small group of patients, and therefore relying on these measures is something that should likely be spared only for cases that haven't been adequately managed through more conservative methods mentioned previously. Recently, there has been more interest in using measures to treat phantom limb pain other than medications, injections, or surgeries. The appeal of this is that, if effective, it's something that patients can perform as another tool for controlling pain. These are based on our understanding of the phenomenon of cortical reorganization and the deduction that if we can modulate the input that is being registered by the brain, we can restore a more normalized brain pattern and thereby improve pain. One such treatment is mirror therapy or mirror box therapy, which is where a mirror is used to recreate an image of the intact limb, and exercises are performed while looking at that image. Though studies supporting this are small as well, they have been shown to have good effect, at least in a subpopulation of individuals with amputation. The graph you see in the middle of this slide is from a study in which patients with amputation were split into a group receiving mirror therapy and two groups not receiving mirror therapy. All those that received mirror therapy experienced a significant decline in their pain, while those that did not either had no significant change or even worsening of their pain. What's interesting is after 4 weeks, all patients in the study were switched to receiving mirror therapy, and all patients then experienced reduction in their symptoms. Incidentally, mirror therapy has also been used in other conditions such as stroke and chronic regional pain syndrome. Another treatment that has been used is graded motor imagery, in which the brain is exercised in measured and monitored steps, which increase in difficulty as progress is made. There are typically 3 different components to a graded imagery program, the first of which is left-right discrimination, where an individual is shown images of a limb in various orientations and asked to determine as quickly and as accurately as possible which side, left or right, they are looking at. An example of such images is shown in the picture on the left. Those with phantom pain are often shown to have greater difficulty with this task, and the thought is that improving proficiency and I think this just timed out. Can you still hear me? Hello? Yeah. Okay. Those with phantom pain are often shown to have greater difficulty with that. Oh, I said that already. The next progression is explicit motor imagery, in which the individual is charged with picturing, performing specific tasks with the amputated limb. such as turning a knob with the wrist or curling the toes. The final progression is to mirror box therapy, which we had just described. With this, as well as other treatments, both medicine and non-medicine-based therapies, improvement in pain is reflected by a normalization in brain activation, as shown by functional MRI scans. What you see in the image on the right is response in a patient with phantom limb pain to a motor imagery program. The rightmost pictures are the activation patterns of a control subject without pain. The leftmost pictures are of a study patient with phantom limb pain. After completing a motor imagery program, those areas of activation are shown to have normalized somewhat, as represented by the pictures in the middle. Though patterns are not exactly the same as a control subject, there's been a clear response to the treatment in this particular patient. Moving away from phantom pain, there are other types of nerve-related pain that may be experienced after amputation. The first is hypersensitivity of the limb to touch or pressure, or even allodynia, which is the experience of pain with a stimulus that is not ordinarily painful, for example, a light touch to the skin. These are related to sensitization of the nerves in the pain pathway, and therefore medications we use to treat this are similar to the medications we would use to treat phantom pain itself. In my experience, this hypersensitivity is very often days to weeks after amputation and gradually subsides. Aside from medications, desensitization techniques can be used to get the limb reaccustomed to things like touch. These techniques include gently rubbing different texture materials over the skin. This is what you see in the picture to the right. Other techniques that some find helpful are distraction and/or breathing techniques, which can be taught by a psychologist. A neuroma is a swelling of the nerve ending that very commonly occurs after the nerve has been cut, as it is in the case of an amputation. This can be painful if that nerve ending is exposed or pressure is put on that nerve ending. Though many, if not most, severed nerves develop neuroma, not all are problematic. Surgeons typically will attempt to bury the nerve ending within soft tissue to protect it when performing an amputation. If this becomes painful with prosthetic wear, attempts are made to adjust the socket to provide pressure relief to that area. And if avoiding the pressure is not sufficient to provide pain relief, neuroma can be injected with a combination of numbing medication and steroids. Other treatments, such as pulsed radiofrequency treatment, have also been tried. Chronic regional pain syndrome, or CRPS, can occur after physical trauma, where over time pain does not improve, but instead the patient experiences, quote, nerve-type pain, such as hypersensitivity, as well as skin color and temperature changes. Medications are used for this, and in refractory cases, interventional treatments such as nerve blocks are also utilized. As stated before, mirror box therapy has also been used to treat this condition. To those of you who are prosthetic users, I'm sure it comes as no surprise that you can experience pain while wearing the prosthesis. This also can have multiple causes, and careful analysis can go a long way in determining the cause. Listed are some of the possible contributors to pain while wearing a prosthesis, which we will go over in more detail. Let me first start by saying that very often pain issues can often be a matter of employing simple fixes that don't involve making major changes to the prosthesis or its components. For example, oftentimes pain can be resolved by adjusting the amount of socks that are donned with a prosthesis. So, being knowledgeable about when more or less prosthetic socks are necessary to improve fit is an absolute necessity. Otherwise, a prosthetic user is likely to encounter continued issues no matter how many changes are made to the prosthesis itself. Nonetheless, if we have determined that the prosthesis is being donned properly with the appropriate amount of socks and there is still pain, the fit warrants closer investigation. One of the things we try to determine is whether the pain is diffusely spread through the limb or localized to discrete points. The use of simple supplies, such as lipstick to mark a suspected area of focal pressure, or putting a sock directly next to the skin as a poor man's pressure map, or placing a clay ball in the bottom of the socket are often methods employed by therapists and prosthetists to determine whether there is too much or too little end bearing. And all of these can give valuable information as to whether changes need to be made to the socket. As far as anatomic abnormalities, heterotopic ossification or abnormal bone formation can occur after an amputation, as well as with other conditions such as stroke, brain injury, and spinal cord injury. This excess bone may cause pain if it produces excessive focal pressures within the prosthetic socket, and may or may not inhibit range of motion, depending on how close it is to the joint. This is managed as conservatively as possible. Once the bone has formed, it will remain there unless it is surgically removed, but discomfort can oftentimes be improved or resolved by providing appropriate pressure relief within the existing prosthetic socket or recasting for a new socket to accommodate for the change in limb shape that has occurred. If pain cannot be managed adequately with these measures, or lack in range of motion significantly impairs function, surgical removal may be necessary. But this is often deferred for several months to let the bone mature. Joint contracture, or tightness in the joints, can cause pain while wearing a prosthesis if it either cannot be improved with stretching or accommodations in the alignment of the socket are not made. This is because the angle of the limb does not match the angle of the socket due to limitations in range of motion, and the rotation of the socket relative to the limb can cause increased focal pressures, which can be painful or even cause skin breakdown. Joint contracture is something that has the potential to be improved by stretching, as in the case of a muscle which has gotten tight from a short period of disuse, or can be fixed, where it cannot be improved without more aggressive measures, such as when there is heterotopic bone formation close to a joint. Contractures should be evaluated by a clinician and are typically managed conservatively with stretching. It may take time to determine whether a contracture is truly fixed or not, as the range of motion restored with these conservative measures is gradual. While a patient is participating in a stretching program, oftentimes the alignment of the socket is adjusted by the prosthetist to accommodate for the range of motion limitations of the joint at that given time. This can and usually should be changed as the range of motion improves. If, however, conservative management fails, more aggressive measures can be taken, such as manipulation of the joint under anesthesia, tendon lengthening, or removal of heterotopic bone. Consideration for any of these measures requires a referral to an orthopedic surgeon. Speaking more on the alignment, a malaligned prosthesis can cause rotation of the socket about the residual limb. In the picture shown, the alignment of the prosthesis is causing what's called a lateral thrust, where this individual has a bow-legged appearance when putting weight on the prosthesis. In this case, the prosthesis is rotating clockwise about the limb, which places pressure on the inside of the knee and outside of the end of the residual limb. The solution is, of course, to correct the alignment. I must stress that any adjustments to the alignment of a prosthetic or its components should only be carried out by a prosthetist or a clinician. Attempting to change the alignment on your own could result in increased pain, skin breakdown, or in lower limb amputation, joint instability, and falls. Scar tissue can also be a significant cause for pain while wearing a prosthesis, as scar tissue can either be adhered or tacked down and relatively immobile, or be firmer than the surrounding healthy tissue. When the skin is adhered, as you can see in the picture on the left, the traction from pushing the limb into the socket can cause a tugging or tearing effect, since the immobile skin cannot slide along the surface with that traction. The firmness from underlying scar tissue can cause increased focal pressure, which can be painful and cause skin breakdown as well. Imagine stepping on a soft foam ball versus stepping on a golf ball. The firmer golf ball will cause more focus pressure and discomfort than the foam ball. In order to improve the mobility of the adhered skin and scar tissue, skin mobilization and massage are performed. This is something patients can easily to do, and believe it or not, skin mobilization can begin as early as within the first couple of days after an amputation. During this period, aggressive mobilization, of course, isn't performed, as care is taken to make sure the skin at the incision remains well opposed to allow the skin edges to heal together. Once staples or sutures are removed, however, massage across the incision line can begin, as shown in the bottom right image. Deeper, tough scar tissue can be improved by massage to the individual's tolerance. When the scar tissue cannot be significantly improved, or while measures are being taken to do so, the prosthetic fit should be checked to ensure that any traction or pressure over the involved areas is minimized. Aside from pain that is directly related to the amputation, there are also associated conditions, which in and of themselves can cause pain. Ischemia is experienced far more often in individuals with lower limb amputation, which is due to vascular disease. Blood vessels carry oxygen and nutrients to tissues and metabolic products away to either be broken down or removed by the body. In individuals with impaired circulation, there is less available oxygen to the tissues, and byproducts such as lactic acid accumulate in the tissues, causing claudication, or the cramping pain that is characteristic of vascular disease. Symptoms that may suggest ischemia are a cool limb with bluish discoloration, and the pain that experienced can often occur after walking a specific distance and resolves with rest and extra time needed for the limb to get adequate oxygenation. Oftentimes, individuals will find themselves dangling their leg off the bed in order to get relief from their discomfort while they sleep. Any of the previously mentioned symptoms warrants evaluation by a physician. This evaluation will involve a physical examination and can include further evaluation of pulses with a Doppler, which makes faint pulses which might not be detectable on physical exams audible through a machine, as well as imaging. What you see to the right is an angiogram, or a picture of the arterial tree as it branches into the legs. Diagnostic images are viewed as if the patient is facing you, so the right leg is on the left-hand side of this image and vice versa. What you see is that the blood vessels in the right leg, which is actually the leg on the left in the image, form a nice continuous bright line down the entire limb. In comparison, in the left leg, that circulation is disrupted in the middle. There are medications that are commonly used for peripheral vascular disease, such as Plavix, which impairs platelet aggregation and thereby helps prevent blockage of the vessels. There is a role for exercise in improving claudication pain. If we look back at the image, while the blood flow is disrupted in the left leg at around the level of the knee, there is blood flow. This is because if blockage to a vessel occurs over time, the body can establish blood flow past that area by formation of what are called collateral vessels, which are the smaller vessels you see running down that leg until that nice bright signal picks up again further down. The formation of collateral vessels can, to some degree, be promoted by exercise, but this should be done carefully with the guidance of a therapist and physician to reduce the risk of overexertion and abruptly compromising the blood supply to the point of endangering the limb. I should point out that any change to the blood supply that happens gradually can be compensated for in the ways we just discussed. However, compromise of the blood supply that happens abruptly could constitute an emergency and should be evaluated by a professional immediately. In such cases, an interventional procedure such as the placement of a stent to open the vessel or bypass surgery where circulation around an area of blockage is established by creation of a new vessel may be necessary to reestablish adequate blood flow. Aside from associated conditions, there are also secondary conditions, those that are not directly caused by the amputation, but can occur from compensations that may have occurred after the amputation. Many types of musculoskeletal pain or aches and pains in the muscles and joints may be among these pain generators. Of course, pain from pre-existing conditions such as arthritis can also persist or be made worse by increased demand on a joint. Deconditioning can also cause pain, not just from generalized muscle fatigue and soreness, but by potentially forcing an individual to rely on muscle compensations which place undue strains on other muscles and joints. Putting some numbers to this, it has been found that those with lower limb amputation on one side of the body have up to 23% force asymmetry between the limbs. In the case of lower limb amputation, more time is spent on the intact limb. Because of this, there is actually a higher prevalence of knee pain in the intact leg, not only in comparison to the general public, but also compared to the amputated limb itself. And because of the increased reliance on more proximal muscles, or muscles closer to the body, there is a higher incidence of osteoarthritis in the hips. Finally, the rates of low back pain are also higher, 52 to 63%, as compared to 15 to 45% in the intact limb population. There is also a 43% prevalence of scoliosis and 76% rate of degenerative changes. If we look at some of the common changes after amputation, we can get a better insight into why. Decreased range of motion in a joint leads to increased compensatory postures and muscle usage. For example, in someone with tight hip flexors, which are the muscles which bring your knee up towards your chest, in order to stay upright, that person may be forced to overarch his or her back, which causes increased pressure on the posterior elements of the spine as they press closer together. And that, in turn, can cause low back pain and can predispose to joint degeneration. This is shown in the upper left-hand picture. A limb length discrepancy, where the prosthetic limb is either longer or shorter than the other limb, will cause an individual to have to bend his or her spine in order to maintain an upright position. This is called compensatory scoliosis. With this compensation, there is asymmetric muscle demand, where the muscles on one side of the spine are forced to work harder and therefore can experience aching and discomfort. In patients with upper limb amputation, those musculoskeletal issues are obviously moved up to the arms, upper back, and shoulders. It's not as clear whether or not the prevalence of low back pain is any higher than in the general population. So from what we discussed in the previous slides, it shouldn't come as a surprise that a lot of what we assess for is strength, posture, and range of motion. Work on stretching and strengthening to avoid poor posture and working muscles beyond their capacity. Use coping strategies. While pain is not, quote, all in your head, there can absolutely be an emotional component to pain, and getting worked up can definitely make that perception of pain worse. Learning how to calm your reaction to pain can improve the pain itself. What might you need help with? Certainly if your pain, despite all the measures you are taking, is still significantly bothersome and requires medication, even over the medications, should be discussed with your physician. Many medications require prescriptions, and your specific symptoms may influence the choice of one type of medication over another. All adjustments to a prosthesis should be performed by a clinician. Never try adjusting this on your own, as it can make either your symptoms worse or make the prosthesis unsafe for use. Any assessment for a new prosthesis or for any procedure or surgery to treat the pain requires evaluation of a physician. And finally, education on the proper techniques for all the pain management strategies we discussed should be sought out before doing these independently in order to ensure effectiveness and safety. In conclusion, amputation-related pain is a complex and variable problem with multiple potential causes. But this pain is modifiable, and the goal in pain management is to modify it for the better. Amputation-related pain can have multiple causes, often occurring simultaneously. The problems often require different solutions, and medication should never be the only tool. Optimal management means active participation, usually in multiple strategies, to the most effectively reduce your symptoms. Thank you all so much for your attention and for giving me the opportunity to speak with you.